Good morning, everyone. My name is Hudaa Mehkri. I'm a nephrology fellow at Sheikh Khalifa Medical City in Abu Dhabi. Today, I'm going to be talking about extreme presentations of a rare renal disease, which is, I cannot move my slides for some reasons. Yeah. So a renal disease, which is so rare that its prevalence is only 1 in a million cases. It is caused by C3 complement deposition in the glomeruli, leading to the kidney injury and impairment. Hence, it is called the C3 glomerulopathy. So our first case is a 21 years old female who presented with frequent headaches and high blood pressure readings. At the age of 10 years old, she presented with a history of presumed post-streptococcal glomerulonephritis. She was treated and her creatinine went back to normal. However, her proteinuria persisted after the disease, which is unusual for post-infectious glomerulonephritis. And at that time, she was advised to undergo renal biopsy to see the actual cause, but her family declined and she lost follow-up. 11 years later, she's presenting with hypertensive urgency and severe renal impairment. When she came to us, her creatinine was 380. She had a microscopic hematuria and a nephrotic range proteinuria of 4.5 grams. She had a low C3 level in her serum. All other serologies were negative. We did a renal biopsy this time, and it showed features of C3 glomerulopathy. Unfortunately for her, her fibrosis index was quite high. It was 55%, which is considered very severe. So given her advanced renal disease and severe fibrosis, we did not treat her aggressively. In fact, we just gave her a short course of oral steroids. We also ordered for a complement panel, which we're going to be talking about later. The second case is a 32 years old female who presented with weakness and bilateral flank fullness for a few days. She has a history of non-steroidal anti-inflammatory use for a few days for a shoulder pain. And she came in with a creatinine of 230, which was normal 1 month ago. She also had a sterile pyuria. There was no hematuria or signs of UTI. She had subnephrotic range proteinuria of 1.2 grams, and even she had a low serum C3 levels. Her ultrasound showed a normal kidney size with increased echogenicity. At that time, our suspected diagnosis was acute interstitial nephritis, given the fact that she was taking NSAIDs and she had a sterile pyuria with no RBCs. However, her low C3 levels were not really explained. So to our surprise, when we did the renal biopsy, it turned out to be a C3 glomerulopathy. And she had a fibrosis index of only 2%, which was really good. In fact, the patient did not require any treatment. She was improved on conservative management and no immunosuppressions were given. Her creatinine went back to normal within few days. So let's talk about this rare disease, C3 glomerulopathy, and the complement system. So the term C3 glomerulopathy is relatively new term. It was first adopted by the expert consensus in 2013. It is caused by dysregulation of the alternative complement pathway. It is mainly a histopathological diagnosis, and electron microscopy is needed to differentiate between its two forms, which is dense deposition disease and the C3 glomerulonephritis. Around 30 to 50% of the patients will progress to end-stage renal disease within 10 years of the diagnosis. And unfortunately, the recurrence rate post-renal transplant is also very high, reaching up to 90%. And 50% of those patients will lose their allograft within 10 years of renal transplantation. So the clinical presentation is like any other glomerulonephritis. They can present with hematuria, proteinuria, edema, hypertension, you name it, okay? But the key feature is that they have a low C3 serum, low C3 levels. The differential diagnosis includes post-infectious glomerulonephritis, monoclonal gammopathies, C3 glomerulonephritis, and the dense deposition disease. So as we know, we have three complement pathways: the classical complement pathway, lectin pathway, and the alternative pathway. The unique thing about the alternative pathway is that it's always active and it needs regulatory proteins to keep it in check. Any defect in these regulatory molecules can lead to overactivity of alternative pathway, leading to the development of this disease. It can be either genetic or acquired. Acquired is more common, and it is mostly due to autoantibodies. So the diagnostic workup, as we said, renal biopsy is the key. You have to rule out infections and post-infectious glomerulonephritis in the last 12 weeks. Also, we have to rule out paraproteinemia, especially in the elderly gentlemen. Complement biomarkers and the complement gene testings are also needed. So these are the biomarkers and the genetic tests that we do usually. It is recommended in all the C3 glomerulopathy patients, and it often requires a specialized labs. So it's not available in all the hospitals. Usually it's a send-out lab, actually. So histopathologically, this is what you see. This is the light microscopy. If you can see my cursor, you see this is the glomerulus, and it is lobulated and full of cells. This is the immunofluorescence staining for C3 dominantly. And this is the electron microscopy, and you can see these dense depositions are actually the depositions of C3 complement in the basement membrane. So coming to the treatment, you have to treat them basically as any CKD. All patients should have a controlled blood pressure, low sodium diet, control other comorbidities, and the lipid control. In moderately diseased patient, will benefit from prednisolone and mycophenolic acid. In patients with severe disease, we might consider anti-complement targeted therapy like eculizumab. So that's the end of my presentation. Thank you so much.